Great. Well, welcome to this Friday initial edition of our fall webinar series. Today, we're going to be talking about preventive services and how to bill them for RHCs. Of course, we're here on behalf of the Illinois Rural Health Association, of which I am the current president. Diane Potts is the president-elect, and Margaret Vaughn is our executive director. So we're happy to be here today. Let's get started. That's me, North American Healthcare Management Services. I also wear a new hat, which is directly relevant to what we're talking about today, and that is Executive Director of the Rural Advantage, our accountable care organization we have put together for rural health clinics and FQHCs. North American, we've been in the billing sphere, rural health clinic, FQHC implementation for a long, long time, down in the weeds, doing billing and helping these facilities get started. So we're down in the weeds with you all day, every day. In the course of doing that kind of work, it became abundantly clear to me that we need to have a conversation about how to bill preventive health services. So I'm going to start with some of our basics. CG modifier review, how to get that on a claim with a qualifying visit, what constitute our qualifying visits, actually reporting the preventive services, a big distinction between same-day billing and standalone visits, with a lot of confusion out there on how to bill either of those with sick visits. We always lose in the mix all of the other preventive services that are available to be billed. So finally, we're confronted with our telehealth visits and how to deal with those. So we're going to cover some ground today, starting with the fact that I personally have been doing a lot of reviews on behalf of Rural Advantage participants and hopeful participants on what their preventive services claims look like. Out of 10 that I reviewed, one had it right. They've been all over the map. In addition to many of us maybe on various social media forums and other listservs, for example, the National Association listserv, there's just a huge amount of don't do it this way advice being given on those forums. One person I recently came across just, admitted to 5 years of overpayment for their hospital organization on a social media post, which I would probably be upset about were I one of the people, overseeing that person. So here are some of the misconceptions. We've got to have a 99201 through a 99215 on an RHC claim for it to be paid. That is false. Conversely, the other issue is since we can only get billed, or we can only get one encounter paid at a time, we shouldn't report sick visits or annual wellness visits together. Or since only one encounter is paid, we can't provide a sick visit and an annual wellness visit together. So that is wholesale false. A huge misconception I frequently come across. We cannot send patients away, particularly on the basis of we only get one encounter payment out of this, so you patient have to come back so I can do an annual wellness visit on you. Or I'm going to do your annual wellness visit on you and then come back for your sick visit. I think that would be worse. The one time I've been giving a presentation in person and had a CMS person approached me, I'll say, right after I stepped off the stage and I got a finger wag was when these first came out and we were talking about, oh, just have the patient come back for their annual wellness visit because we don't want to disrupt patient flow. We don't want to disrupt things too much. Let's have the patient come back and we'll do the annual wellness visit. You don't tell the patient to come back, period. I said, yes, ma'am, you're absolutely right. I do not tell patients to come back for annual wellness visits. So we cannot have a policy that says, leave and come back for this. CMS wants us to treat the patient while they're here. I think those of us in the clinics understand the degree of transportation security that many of our patients have for various reasons. And so that's a big driver of this. And plus, our patients are sick. They're in the clinic. That's when it's time to see them. Now, of course, the patient shows up and, the provider can or can't do something. That's a totally different thing. But having policies in place to say, leave and come back so we can do your annual wellness visit because we only get paid the encounter under this scenario, that thinking needs to go away. Often, like I just said, that patient does come in, and particularly on the ACO, we're talking about, in particular, our patients that are really sick, have multiple raging chronic conditions, and often come in because they know the annual wellness visit doesn't have any cost associated with that. So it's not possible nor appropriate to put a policy in place to handle that. Our providers are trained to exercise, and we want them to exercise their medical judgment. So if a really sick patient comes in, provider needs to treat that patient. So I want to just reiterate, of all the things we talk about today, medical judgment, medical decision-making takes priority on all of these. And we can't put that in a policy. Provider in front of the patient, they're the ones making the decision based on that patient's condition. But we can provide annual wellness visits and sick visits on the same day, and often should. We want to be doing that. So let's clear up the myths about how we do that. First, we know about our qualifying visits. One line item per encounter, represented by a 052X revenue code. And we're going to report a CG modifier on it. We'll get to that in a second. And payment and applicable coinsurance or deductible are based upon our qualifying visit line. We've got to report all of the charges with our qualifying visit, and our totals have to subtract any preventive visits out. And again, we can use 052X or revenue code 0900 to indicate the primary reason for the visit. Now, I've just redone my slides quite a bit, and I know I have a CG modifier slide in here, and I'll bet we're about to get to it, but we're paid for preventive services, in effect, the professional component, when our frequency limits and program requirements have been met. For most of our preventive services, including the Welcome to Medicare, that's IPPE, annual wellness visits, and the other preventive services with these grades, we, in effect, we get the encounter out of that visit. So anything on the qualifying visit list, we get the encounter. For preventive services, copay deductible is waived, and we're going to indicate the majority reason for the visit. And here's part of the key sentence that may be subject to coinsurance and deductible. That gets us a little crossways with some of our preventive visits, but our modifier CG represents the primary reason for the visit, and it can be interchangeable. We'll see that momentarily. Look at this. We're allowed to report additional 52X or 900 revenue code lines. We're allowed to report. So one of those myths were, oh, we only get one encounter, so we can't report the, no. A big part of the problem is when we've talked in terms of these other encounters, we've talked about them in terms of being payable or billable, but we need to talk about them in terms of being reportable. We need to report them, whether or not they result in an additional encounter payment needs to be eliminated from particularly our provider's conscience when they are selecting and performing services. So often our providers get hung up, I think, or we've trained, let me say, we've trained our providers to only pay attention to which encounters they're going to get paid for. And we need to eliminate that thinking, because we can report multiple line items on here that would otherwise be encounters, but we're still only going to get one visit. Now, I digress a bit. Copayment and deductibles, we know we've got to remove our copay and deductible from charge lines for preventive services. We cannot charge our patients copay and deductible amounts for preventive services. We have a same-day billing concept. Some of our preventive services are eligible for a same-day payment. When they're performed in conjunction with another sick visit, we get another encounter, and that is the Welcome to Medicare or initial preventive physical exam. Welcome to Medicare IPPE G0402, eligible for same-day billing, but it's the only one eligible for same-day billing. So when furnished on the same day as another encounter, it's eligible for a same-day encounter payment, but no other preventive visit is. No coinsurance is applied to the Welcome to Medicare. And here's the claim example. From our RHC reporting FAQ, the CG is optional. It's the only service I know of. It's optional for a rural health clinic visit that is paid as an encounter. So Welcome to Medicare only, we do not have to put the CG modifier on that. When we report the CG modifier with a sick visit, which we can do, as we've established, on this claim, we don't have to put 2 CG modifiers on it. Actually, we can. CG modifier is optional with our Welcome to Medicare visit, but we don't have to. So that's one thing that makes it interesting. So this is a Welcome to Medicare, specifically Welcome to Medicare, and office visit. And look at this. You know what all of my claim examples in the past had were 99213s. I've eliminated 99213s from anywhere because guess what? 99214 is your new 213. 214 is your new 213. Why do I say this in today's context? Because our preventive visits are focused heavily on treating chronic conditions. And a 213 is 2 chronic conditions with an acute problem or one of those chronic conditions exacerbating. Those are healthy patients for most of us. So for most of us, just on the face of it, when we're seeing patients with multiple chronic conditions, more than 2, we're generally talking about 99214s. That 99214 for your diabetic, hypertensive, does your patient have hypertension because of their diabetes? That's another thing we're going to address. and COPD and whatever else they have. 214, get the encounter. Welcome to Medicare. We're going to lay out an annual, here's our patient's current status, and that welcome to Medicare visit is hopefully going to lead to other preventive services based on those chronic conditions reported during the welcome to Medicare visit. All of our other preventive screenings are standalone encounters. You know what? I noticed a horrible mistake in some of my old presentation material. I had I'm supposed to be the expert and I'm getting them reversed. So if we have confusion on these, don't feel badly. It's a confusing topic. And even the supposed expert easily gets tongue-tied on it and reverses language. I had my language reversed in some old presentations. I'm not even going to say it because I don't want to confuse the issue. Welcome to Medicare, same day bill. Other preventive screenings, standalone encounters. A standalone encounter is one where if only that happens today, I get paid an encounter. The clinic is paid an encounter. If it's furnished on the same day, see, that's why it's confusing. It's the same day as another visit. It's not a separately payable visit. We only get one encounter, but we need to report it. Our standalone encounters, even if they don't result in any additional payment, we need to be reporting those line items. We know that other preventive screening, think annual wellness visit, we're about to look at one. It's going to get on the claim. It doesn't result in an extra encounter payment, and there's no co-insurance or deductible on it. So why do we report it? It's very important to report it. Medicare needs that information. You as a provider need to do that for your patients. The provider needs the service. So all the way around, even though it's not going to affect, it's for information only, we need those services on the claims. So we're talking about annual wellness visit, and let's not forget those come with personalized prevention plan services. That's a mouthful. Personalized prevention plan services with the annual wellness visit. And then the point being, our subsequent annual wellness visit hopes to follow up on that prevention, the personalized prevention plan. Advanced care planning by itself is a standalone counter. So my mother, unfortunately, we just came across the need to make sure her advanced care planning was up to date. And that conversation by itself is an encounter. When it happens with another sick visit, which of course this did, then it's for information only, but we need to get that information on the claim. And we know we have a host of other Medicare preventive screenings, which are also all standalone encounters. We're going to talk about many of those separately. So I just want to reiterate, a standalone encounter is one that if it's furnished on the same day as another billable visit, we only get one encounter. But it's rendered by itself, it's paid at the AIR encounter rate. Standalone encounter, but we need to report these. Most of us know what the annual wellness visit is. Welcome to Medicare is only available for 12 months. Welcome to Medicare's first 12 months of the patient's eligibility in Medicare. And after that 12 months passes, they're never eligible for another welcome to Medicare. So if there's never a welcome to Medicare visit, and we missed and we're out of the first 12 months of the patient's eligibility for Medicare, we can provide and document and bill an annual wellness visit. And then the subsequent annual wellness visit, the patient is only eligible if they've not had an annual wellness visit within the last 12 months. Both of these are standalone encounters, can be billed alone if that's the only thing that happened. And if it's on that same day, oh, hey, doc, I'm coming in for my annual wellness visit. Oh, but I do have 10 raging chronic conditions. We're going to report it even though it won't result in extra payment on that same sick visit. So here's an annual wellness visit. My price throughout this will be $120, just so we keep it straight. And in this instance, we'll of course report the CG modifier from the RHC reporting FAQ. The only preventive services are done for that day, we'll report that with a CG modifier. The preventive code, which represents the primary reason for the visit. And I'm not sure what just happened to, I think I hit end. Pardon me, folks. Sorry about that. Get back to where I was. Hit end instead of page down. I thought, oh no, did I delete half my slides? That would be bad. So that's not where I was either. Here we go. Subsequent annual wellness visit, CG modifier. Now look, here's one way we get it wrong. Modifier 59 and 25, most of us in the next example would be inclined to put a modifier 25 on an office visit and a subsequent annual wellness visit. That's how we have to do it in the fee-for-service world. In our instance, 25 only indicates a subsequent encounter today. So if the patient comes back and they hurt themselves or get sick and need another visit and they come back, that's when we use modifier 25. We do not use modifier 25 to distinguish an office visit from another line item on today's encounter. So modifier 25 does not get used to distinguish the E&M from the annual wellness visit. This is how we properly report. And remember now, 214 is where our curve is going to be on our E&M usage, because most of our patients have more than 2 chronic conditions. The annual wellness visit gets reported, but this is for information only. Notice we have a $270 charge on this, but Medicare is only going to apply coinsurance based on the $150 99214. The same thing happens here. In this example, we've got an office visit, our 99214. Oh, I missed changing the date of service on there. Excuse me. Not supposed to be a venipuncture in 2021. We're bundling the venipuncture with the office visit, but we do not bundle the annual wellness visit. So some of our practice management systems are going to have some trouble with this logic on what to bundle and what not. It does not matter what order these line items are in. The office visit can be last. Of course, it would be before the total charge. But if, for example, our practice management pulls these out in order of the revenue code and the venipuncture would come first, for example, that's fine. It's just we have to get the CG modifier and the amounts bundled properly. Otherwise, we can't have these in different order. This is how to properly report an office visit with an annual wellness visit. It also gets a venipuncture at the same time. I want to make note, 2.6 work RVU for the annual wellness visit. There's some incentive for our providers to be performing these. 2.6 work RVU. In this example, take a look. Now in this example, it's hard to see, but over here we have, this is a subsequent annual wellness visit. The subsequent annual wellness visit got the CG modifier in this instance. This is before the RHC Modernization Act. And look at the cap on there, 86 bucks. If anyone needs a reminder of why we needed the RHC Modernization Act. But you'll notice there's no coinsurance and deductible on this. Actually, the office visit turned out on this to be for information only, which probably wasn't the intent on that claim. But you can see we have some variation in what we can do on those. Now, remember, we have a bunch of other standalone encounters. We have pelvic screening, prostate, glaucoma. The prostate glaucoma screenings, those have coinsurance on them. The rest of these standalone encounters do not. So I wanted to introduce these others. Pap smear is a standalone visit. Depression screening, obviously going not in chronological, not in order of the code, excuse me, not in chronological order either. These are all our standalone visits because here is what a well-woman exam would look like when properly reported to Medicare. And this is a first instance where we easily can see where we have multiple preventive visits being reported at the same time. I clearly didn't update my dates on this, but subsequent annual wellness visit, breast and pelvic exam, pap smear, all get rolled into one visit. Notice we're not bundling the charge amounts, and we have, hopefully, I think my dollar amount's off there too. No, my dollar amount's right. So $300 in total charges on this. We'll get one encounter out of that. Now, about a subsequent annual wellness visit by an RN. You know, our annual wellness, the subsequent annual wellness visit, they don't require a physician or provider to do all those components. So in the events where we have a clinical visit that we've done an encounter, our providers provided a 99214, we send the RN in to do the subsequent annual wellness visit and get credit for it. Why not? I think so. Matter of fact, we need to do that. And I'm going to tell us why I'm going to tell everyone why we need to do that here momentarily. Of course, if an RN does the subsequent annual wellness visit, no claim could be submitted for the annual wellness visit only. So we can only submit the subsequent annual wellness visit performed by an RN if it's on another sick visit. So that's perfectly doable. It would be the same way as one of our providers did that. Now, these provider stick your head in visit to say hello to get it to count as an encounter, sticking your head in and saying hello will not get it to count as an encounter. The provider has to provide the majority of the care, which has to be documented in the note, and stick your head in visits don't count. But RN doing this visit after your provider's done a 214? Absolutely. We're going to see in a moment again. It's a nice RVU pickup when we do that. Medicare used to have this more in a chart orientation. This is a chart orientation, but what I meant, a PDF that we could download and it had it all charted out. Now, Medicare has, and in these slides, which we will distribute, in these slides, this is linked so that you go to each of these separate preventive services and Medicare is going to give you all the codes, all the information about that, etc. Now, it does say in the descriptions of all of these that these are available in primary care settings, but they would not be expected to be rendered in inpatient hospital, SNFs, or a rehab unit. So it does have, there is comprehensive information. I would suggest if you're curious about any of these, but here's the thing, say we do a sick visit and any of the rest of these, you could tag on, you know, how much tobacco cessation are you doing? I bet you're doing quite a bit that's not actually getting reported. So how much obesity screening are we doing? How much diabetic prevention are we doing? Here's where we start getting into where it could be beneficial that even though our RN wouldn't get the line item, we can still report the service. Medical nutrition therapy, we can still report the service and start getting credit for it with Medicare. So I encourage everyone to go check out that preventive services chart and then look at our wRVUs. I've been doing a host of implementation projects on our ACO. And part of the problem is getting around. All of us are programmed to only think about the encounter payment. Employed hospital physicians, yes, they have to think about their directive from the hospital is if you can't get 2 encounters, I shouldn't say is often verges on if you can't get 2 encounters out of that visit, have them come back. You need the 2 encounters. Plus, what we're talking about here, represents an additional payout from ownership, especially if we're on RVUs. But on the provider side of it, well, what do I get out of doing more preventive visits? That's what I'm talking about here. We're doing more preventive visits because that's going to get us higher scores in our ACOs. That's why I'm having this conversation. So then getting provider buy-in is a huge deal. What's the provider interest in the ACO? Well, if you perform these measures, you're going to get more reimbursement up front out of the box because you're increasing your RVUs and we're providing services that the patients need. So once providers open up to seeing what the RVU number is, it does have an impact. So then consider more claims like this, which I think we don't do nearly enough of in our rural health clinics. Established patient level 4 comes in, we see them for their chronic conditions, and unfortunately it's clear, and maybe it's not clear, I'm a pretty healthy young guy and I have an advanced care plan. So we have advanced care plan counseling. We do alcohol screening. We do an obesity screen. And we report all of these services. And boy, what we're doing for patient attribution here for any ACO participation really starts to focus the mind, not to mention the care, of course, that this patient is getting that they clearly need. And the CG modifier goes on, of course, the office visit, and that's where the co-insurance and deductible will go, based on $150 and not based on $325. But this is what we're encouraging as many people as we can to do. Not just report. I think in most cases, in most rural health clinics, we probably just report the 214 on this service. So here's an annual wellness visit with the same thing. Annual wellness visits with additional service. Now that alcohol screening, obesity screening, here's what I think. I'd love to have make your whole menu of services available to patients so they know what all of the preventive services are that are out there and available to them. Of course, we don't want to have an alcohol screening day. We don't want to have an obesity screening day. That probably wouldn't be, let's popularize whatever we have going on in our lives here, see who's in the parking lot. But we could have hey, make these available to the community. You got new nurse practitioners or PAs or providers that need some volume. So great ways to build them. And, alcohol screening was what, a 0.18 or something RVU. It is a way to build productivity. We know if we're talking about preventive services, Medicare does include flu and pneumococcal. We don't bill those ever. For Medicare, they go on the cost report. And these are the only injections that are payable on the cost report. We frequently get folks that are, thinking other immunizations or injections will be paid. This does include COVID immunizations, that we will put COVID on the cost report. But here's the other trick. Look at the bottom line here. And this is the case in Illinois. Most of our Medicaid plans don't pay for flu and pneumo. It's considered covered in the cost of us seeing that patient, even if we haven't rendered an encounter on that day. So flu and pneumo is a bit of a problem for our Medicaid patients. I couldn't figure out why there was a big scramble to do annual wellness visits during the pandemic and whether or not we could do them via the telephone. As soon as I started, deepening my understanding of value-based care and ACOs, it struck me immediately what was happening. Annual wellness visits are critical for patient attribution. A lot of us are wanting to do our annual wellness visits. So because we had metrics, we're in an ACO, we had metrics we had to meet, we have to get our ACOs, our annual wellness visits recorded. Medicare did allow us the flexibility via MLN SE 20016. Many of you may be familiar with that. That is the document that guides our telemedicine during the COVID pandemic. We can do an annual wellness visit via the telephone. If some of the patient's condition cannot be assessed, we can have the patient self-report elements of the AWV we would normally do in a physical exam: height, weight, blood pressure, etc. And these can be included in the medical record and self-reported by the patient. So we can do telephone visits. Remember, a telephone visit gets reported via G2025. So annual wellness visits via telephone, annual wellness visits via G2025 are both perfectly acceptable. If we're doing an annual wellness, and I just had this conversation this morning, I don't think there's a ton of telemedicine happening in the clinical realm. I don't think there are a lot of us doing annual wellness visits. A significant portion of it. I think a lot of us still have plenty that we're doing, but I think the urgency of this has gone down. But here's a big point I want to make. Cost sharing was waived, right? We can't have annual wellness visits and co-insurance. Medicare for G2025 will apply a co-insurance, so they established that CS modifier so we wouldn't have co-insurance or deductible amounts. Here's the problem. There's no way for Medicare to know when you report a G2025 that the annual wellness visit occurred. We're only capturing the G2025. There's no way to capture the annual wellness visit code. So that's a big problem. The only thing we ever knew to come up with is, and I'd always suggested this at first, but I got myself in a little trouble because once you put it in a presentation and put it in writing, people think it's required. My recommendation was to report the detail with G2025. So report the annual wellness visit, but suppress it and not get it out on the claim, not let it submit on the claim. It would bomb the claim. Claim wouldn't pay. But then you at least have detail so you know what service was provided with that G2025. Otherwise, not only does Medicare not know that you provided an annual wellness visit, you have no idea of what service was provided when you did a G2025, other than going and looking in the patient note. That's the other problem we came across. So we think it's a good idea to report the actual detail with your G2025, but regardless, Medicare still has no way of knowing that you did an annual wellness visit. There's no way coordination of benefits will get that information, and there's no fix that I know of. There's no workaround that I know of. Why is this important? Annual wellness visits drive patient attribution in our value-based care organizations. Patient attribution is based on the plurality of services provided, and they help us win plurality so that we have that patient assigned to us. All of this complicated chart is just to show that patient attribution and plurality of services at the heart of patient attribution. Sometimes many of us are not seeing patients that are attributed to us because we didn't get the annual wellness visit on the claims correctly. HCC coding is what happens when we diagnose our patients. HCC coding is what drives predictors of future healthcare costs for patients. Every year, patients' chronic conditions get wiped clean. Get wiped clean. The analogy is, I've lost an arm last year. Every year, Medicare thinks I've grown back my arm until my amputation is reported once per year. And this is how Medicare gets reported. All of my chronic conditions is if I have reported all of my chronic condition codes reported once per year. Wonder where we're going with this. HCC reporting drives everything we do in a value-based care arrangement. And look at this, it ends up in an HCC risk score. And look what happens on our annual wellness visits if we don't get them billed right. Do you know how many folks I've been coming to looking at their CMS quality data? CMS has all of this data on all providers, and they have no annual wellness visits recorded. It's happening a lot. And it's because we're not getting them on the claims correctly. And that HCC score happens in conjunction with our annual wellness visit, if we're doing it right. So we have got to start changing how we think about our preventive services. We have got to get out of our mind that our priority is whether or not we get 2 encounters. That is no longer the priority. It can be a priority, but the priority is we're getting all of our preventive services on our claims and reported to Medicare correctly according to what we've documented in the chart. And that's how not to wind up with goose eggs on your annual wellness visit compliance, because that's what we're seeing. Here's my telehealth reference. I got through those slides more quickly than I thought I would. Here's some of my other resources that are pretty standard fare. Look at any of those. And then that too has some ancient information about preventive service billing. So let's take some questions. Yes, we're recording this. The slides will definitely be available. Preventive services.